This audio recording will outline our plan to initiate pharmacogenomic testing for the MT-RNR1 amikacin gene drug pair. We will work to implement MT-RNR1 pharmacogenomic testing prior to initiating amikacin within the KU hospital in an effort to decrease severe adverse events. Once we successfully implement within the KU hospital, we hope to expand our processes to other hospitals and health systems in the Kansas City area, as well as expand our procedures to include other aminoglycoside antibiotics. The outline below focuses mainly on the implementation of genetic testing prior to amikacin administration, as this is the most commonly used aminoglycoside antibiotic at our hospital and is the only drug of this class on our formulary. As far as evidence evaluations go, the PharmGKB clinical level of evidence for the MT-RNR1 amikacin gene drug pair is 1A. There are current CPIC guidelines for the aminoglycosides, including amikacin, in patients with mutations in the MT-RNR1 gene. It is relevant to pre-screened patients prior to amikacin administration, as some variants in the MT-RNR1 gene are associated with an increased risk of ototoxicity from aminoglycosides. Genotype testing for pathogenic MT-RNR1 variants will be performed on-site in our pathology lab. There are currently 3 mutations associated with an increased risk of hearing loss: M1558G, M1095T-C, and M1494C-T. After testing, the results will be uploaded to the KU hospital EHR as discrete data. Both patients and providers will have access to this data through the EHR system. Patients will also have access to their genome results via their MyChart Health portal. This way, patients will be able to share their results with other healthcare providers outside of the KU hospital if necessary in the future. As far as reimbursement goes, tests will be covered through drug-related group billing when ordered inpatient. There are almost no cases in which this program would require testing outside of a hospital administration. Therefore, it really would only need to be covered through a drug-related group billing process. This is due to the characteristics of amikacin and its place in therapy. It is available for IV administration only and is not a first-line agent. Therefore, the MT-RNR1 genotype testing is likely to only be required as part of an admission for an inpatient patient. Considering the EHR and clinical decision support, when amikacin is ordered for a patient and a pharmacist goes to verify the order, a CDS or clinical decision support will pop up. This CDS will display genotype results and the order itself will show a color-coded system. The order will show green if there are genotype results available and no pathogenic mutation was found. The order will show yellow if there is no genotype data for the patient, and the order will show red if there are genotype results for the patient and a pathogenic mutation was found. If there are no genotype results available, the pharmacist will be able to order them directly through the CDS, and the order will go back to the top of the queue with the label pending genotype results. Once the results are available, the order will re-enter the queue as normal, and the pending label will drop off. Orders that have genotype results available will show their designated color based on the results. If it is green and no pathogenic mutations are available, the pharmacist can verify the order as usual. Upon verifying the order, an alert will pop up to remind the pharmacist that aminoglycosides may cause hearing loss, and it will prompt the pharmacist to give the patient the education material prior to administering the first dose of amikacin. If it is red and the pathogenic mutations were found, the CDS will prompt the pharmacist with the CPIC guidelines for the MT-RNR1 pathogenic mutations and aminoglycoside use, and state that the use of amikacin in this patient is relatively contraindicated, unless the increased risk of aminoglycoside-induced hearing loss is outweighed by the severity of infection. It will also require the pharmacist to speak with the physician prior to continuing. Once the pharmacist speaks to the physician, they can click Next, which will prompt them to type comments about why they will continue with the amikacin or why they will choose a different option. They can then click Verify or Reject. If they choose to verify, it will also prompt the patient to give prompt the pharmacist to give the patient education handout to the patient prior to administering the first dose. To evaluate the program, throughout the first year of implementation, a number of parameters will be monitored. These include the number of amikacin orders, the number of genotypes performed, the number of amikacin orders rejected, the number of amikacin orders verified, and the average amount of time from order submission to verification or rejection. It will also collect data on patient, pharmacist, and physician satisfaction. This data will be reviewed at the end of a year for future improvements to the program. The physicians and patients that will be educated. The infectious disease physicians and hospitalists will be provided education on the program. They will be presented with the CPIC guidelines, relevant case studies, and procedures for ordering amikacin. This education will be presented live on site or online at multiple different times to fit the most schedules. In this presentation, they will also be shown what it looks like on a pharmacist's end as well, so they understand what delays may occur and why. Patient education will be provided by pharmacists prior to initiating genotyping and prior to administering amikacin. The first session will be basics on pharmacogenomics and its relevancy, and why it's necessary to perform the tests, and this education session will last approximately 5 minutes. An education handout will be provided. The second will be a discussion of the patient-specific results and what they mean, as well as counseling on amikacin.
So here we have a patient handout addressing how pharmacogenomics can help to reduce some of the serious side effects that come with amikacin therapy. We start out with an explanation of pharmacogenomics and why it is important. It is the study of how differences in a person's genes can affect how they respond to medication, which can make medications less effective, or, as we're going to discuss, contribute to some serious side effects. So, how do you know if you have those differences? Your doctor can get you tested before they start certain medications, and this can give healthcare providers some information that will help to decide the best course of therapy for your health. So, what is amikacin and what is the benefit of pharmacogenomic testing? Amikacin is an IV or intravenous antibiotic that belongs to the aminoglycoside class. It is most often used to treat serious bacterial infections in the hospital setting. So, there are some increased risks of amikacin if you have this gene mutation. There is strong evidence that links certain gene mutations with a higher risk of ototoxicity, which is also known as irreversible hearing loss. One particular gene of interest is a mutation in the MTRNR1, and that is known to increase risks when using amikacin. There are some specific genes listed there, gene mutations. And the overall results, your genetic testing will be available for you, so you can look at that. You can share it with other healthcare providers so that they can also help to make best decisions for your health. Overall, the MTRNR1 gene mutations increase the risk of serious side effects for those taking amikacin, and pharmacogenomic testing can help to prevent these issues. And there are some additional links on the bottom for more information.
Hi everyone, hopefully by now you've learned how to use and apply the MT-RNR1 pharmacogenetic testing. And now we'll go through a case to test your knowledge. It looks like we have JP, who is a 57-year-old African American male who came into the ER at the KU hospital complaining of shortness of breath. He states that for the past 3 days he has had a productive cough, chills, and a fever. The vital signs are showed, and the blood pressure is a little low, as well as the respiratory rate. The patient is started on 4 liters of nasal cannula, and a chest x-ray is performed. The chest x-ray results look like they have a bilateral opacities indicative of pneumonia. JP is diagnosed with community-acquired pneumonia and started on vancomycin 1,250 milligrams every 12 hours and cefepime 2 grams every 8 hours for empiric therapy. The doctor then orders the sputum and blood cultures. They were obtained prior to the initiation of the antibiotics. On day 3 of his hospitalization, he's not gotten better, and the cultures came back. It looks like the results are the sputum culture. The isolate for it is Pseudomonas aeruginosa. The blood culture shows no growth. The susceptibilities are also shown for the pneumonia aeruginosus. It looks like it's only susceptible to amikacin and it's intermediate to meropenem. Everything else is resistant. So based on these results, the physician would like to start the patient on a combination therapy of the amikacin and meropenem. He puts in orders for both medications. The meropenem is 1 gram IV every 8 hours for 5 days, and the amikacin is 900 milligrams IV every 12 hours. In this instance, you are a pharmacist verifying these orders. How do you address the following concerns? There are a few questions we will go over here. The first one is the CDS prompts you that JP does not have an MT-RNR1 genotype available in his chart. So what steps do you take and why? I'll give you a few seconds to think about your answer, and then we'll go over it. Okay, put yourself in a real hospital in a real scenario like this. As the pharmacist verifying this order, it is best to order a MT-RNR1 pharmacogenetic testing for the patient, and you can do so, must do so, rather, order the testing through the CDS, and then the order will go back to the top of the pharmacy's queue with a label reading pending genotype results. The patient will then get the MT-RNR1 testing in the hospital, and once the results are available to you, probably after 30 minutes to a couple hours, the order will re-enter into the pharmacy queue as a normal order, and the pending label will drop off. This leaves for you, the pharmacist, to verify or not verify the order depending on the results. The pharmacist orders, and basically you're doing this because you order the pharmacogenetic testing for the patient's safety due to the serious side effects, mainly hearing loss, that amikacin can cause in certain people with that mutated, one of the 3 mutated genes. Hopefully your answer was somewhat similar to that. The next question is, JP's genotype results are available, and he is M.1494C greater than T positive, so that is one of the mutated genes. What does this mean, and how will you address your concerns with the ordering physician? So like I said, JP has a mutation in the MT-RNR1 gene. This is one of 3 of them. So the mutation gene interacts with amikacin and can cause the irreversible hearing loss. Before you go and talk to the physician, make sure you use sources like the CPIC guidelines and or the pharmgkb.org as a resource to back up your suggestion when speaking with JP's physician. You should start the conversation with the physician by expressing your concerns of JP having this irreversible hearing loss when taking the amikacin, because JP has one of the mutated genes that interacts with amikacin. But try to make it conversational by asking the physician's opinion after relaying this concern, and really don't try to come off as arrogant or basically it's my way or the highway type verbiage. You're there to have a conversation with the physician, and a lot of times, the physicians know best for the patient. They just may not have all the information, like with the MT-RNR1 genotyping. So you're there to aid in their care. Hopefully you also had a answer similar to this. And next we will move on to the third question on the next page. Okay, our last question is, after speaking with the physician, together you ultimately decide that the patient's need for the medication outweighs his increased risk of hearing loss. How do you describe your feelings and the decision to the patient? I'll give you a few minutes to think about your answer here. So basically, as the pharmacist that ordered this testing for JP, you should explain to him that it was a specific test to see if he had a gene that could cause him serious side effects or harm when he took this antibiotic or medication that the physician ordered for him to feel better. You should also give JP the patient friendly education material that was on slide 3 of this presentation, and go over it with him, especially to see if he has any questions. And hopefully, a visual will make yours and the doctor's concerns more clear. Then you should reveal JP's results with him for being positive for one of the mutated genes that could cause the interaction with amikacin. He may be surprised, but you should reassure him that you and the doctor talked about how getting rid of his pneumonia is more important right now than worrying about hearing loss. Just make sure that JP is aware and that you and the doctor made the best decision for his overall health. And we'll discuss it more if he has hearing loss after his treatment of the amikacin. With that, thank you guys for listening for our presentation. If you have any questions or would like to contact us, just use our KU emails. They are all our first and last name .ku.edu. And with that, thank you again for listening to our presentation.